Hello CTSNet friends, my name's Joel Dunning and welcome to another edition in our podcast series. It's an absolutely jam-packed series today. We've got an incredible new beating heart transplant technique from Joseph Wu in Stanford. We've got an interesting article on what is the least worst option when a TAVI fails and how long does it take to master robotic CABG. On the video front, we've got some really interesting videos. We've got a whole webinar, we've got pain in cardiac surgery, and we've got a bonkers crazy wonderful video about how you fix a left ventricular free wall rupture. And then I've been spending a week in Papworth, all with the brand new Versius CMR robot. It's some really exciting news for you, so don't go away, we've got a packed edition. So, thanks for tuning in. What a packed edition we've got today. And the thing that really struck out on new papers today for me was this wonderful paper on the first beating heart transplant by Joseph Wu. Joseph Wu is an amazing person. He's the Norman Shumway Professor of Cardiac Surgery at Stanford. What a huge set of boots to fill, but he has filled them plus. He really is a wonderful clinician and scientist. I met him in Australia actually at the Hobart annual conference there, and he just blew us away. He was a total star. And in the JTCVS Techniques this March 2023, he has published just the most phenomenal video. So what's the problem? So we have a limitation of heart transplant donor organs, and so obviously the hope is that we can use DCD donors, patients that unfortunately are not brain dead, so we have to wait until they die once they're extubated, and unfortunately that does produce quite a big ischemic time for the heart. Now the big problem is that you have a big ischemic time as they pass away, and the case he shows in this was 13 minutes, and then you get another big ischemic hit when you take the heart out of the EVHP device and put it in the chest. So that's two big ischemic insults, and that has been proven in studies to show inferior quality of transplant. But Joseph has designed this just wonderful new technique. You have got to check the videos out here. So what he does, he shows us a technique where, we had 13 minutes of ischemia time. Then he explants the heart, puts it in his ex vivo heart perfusion device, which was the Transmedics organ care system, and then he brings it across to his hospital. But this is where the magic happens. So he then, while it's on the rig, he then cannulates the aorta and cross clamps and starts perfusing it with blood from his bypass circuit. So he's there with his recipient. He has a special modified circuit so that he can then start perfusing the heart with the new recipient's patient's blood. So the heart starts beating. So it starts beating, he takes it off the rig, and then he stitches it in beating. So really interestingly, he puts pacemaker wires on the heart, and he starts to take over the heart rate and tries to bring it down to about 60. And then the video shows him suturing in the left atrium, suturing the aorta, then taking two cross clamps off the donor and recipient, and then starts perfusing it, where he then continues the IVC, the pulmonary artery, and SVC. This reduced the ischemic insult quite significantly with this recipient, and it's really an exciting future for heart transplant. So well done, Joseph Wu, star of the future, guaranteed nailed on future president of the AATS and STS and everywhere. So keep a lookout for him. What a star. So the second thing we selected for you was this rather interestingly titled article, What's the Worst Redo Option After Tava? So this combined two really interesting articles. One was from Sunichi Fukuhara at the University of Michigan, Ann Arbor, and this was both published in JACC Cardiovascular Interventions. The first article looked at the STS database in redos after TAVA failure, and the second one was by Gilbert Tang from Mount Sinai, and this was called the Explant to Redo database. And looking at both of these articles, it sought to answer the question of, if you have a TAVA failure, what do you do next? Do you do another TAVA? Do you do a TAVA then an open AVR? What is the safest and what is the most dangerous? So, and the thing that stood out to me was the STS database. They'd found 31,000 aortic valve replacement procedures in patients that had a previous TAVA, and that is a huge number. And so 1,000 had after previous aortic valve replacement. So 1,100 had previous TAVA, a transcatheter AVR, and 600 had a normal aortic valve replacement and then a TAVA because it had failed and then needed surgery, and then 29,000 had just a normal aortic valve replacement and that needed fixing, obviously all biological valves. So now this was the crazy thing. So in these 1,100 patients that had a transcatheter AVR and then needed open surgery, 17% died. 17% mortality in the STS database. That is unbelievable. That is just so high. So in the patients that had a normal aortic valve replacement and then that needed repairing with another open aortic valve replacement, it was only 9%. So your mortality is half if you're explanting a normal AVR compared to a TAVA. Now, I wonder, I guess if you've done some TAVA explants as an open surgeon, you probably really truly understand how horrific it is to take these things out. The wires are everywhere. It's near the coronary ostia. They're designed to never be taken out, aren't they? They're just so much more difficult to take out than an open AVR. But this really is an amazing statistic. Now, they also say that less than 0.5% of TAVAs actually ever need to be redone. So this is a small group, but this is really important because this means that you really have to consider which patients receive a TAVA, because you do not want to do an open AVR on these people, with such a high, nearly 1 in 5 mortality. The second study they showed was the explant to redo registry, and it wasn't so different really. It really backed up the findings of that. They said at 30 days the mortality was 13% if you did an open AVR after TAVA, whereas it was 3% if it was just open AVR then open AVR. So amazing really, and I think this is really important. It really does highlight how important it is to plan the future procedure, even if it is just for 0.5% of patients. The other interesting thing is that a key thing they said was that we really need to estimate the life expectancy of our patients, and they said that actually in all prediction of life expectancy, it's only about 16% accurate. And the best prediction models of life expectancy are only two-thirds accurate as to whether you're going to live 10 years or longer when you're in your 70s. I thought that was amazing, really, and something to just consider. So well done, those authors. Fabulous couple of papers. And if you're involved in TAVA, really do have a look at those. Finally, the third interesting paper we looked at was Mastering the Learning Curve in Robotic CABG. This is a great paper by Amalia Johnson and Michael Halkos from Emory University in Atlanta, and they've done 1,000 robotic lemurs to LAD, and they document their learning curve. They use a variety of methods. They looked at the STS database and their own data as well, and looked at how quickly it sped up. Now, the really nice thing that they publish is that their mortality is absolutely tiny, 0.6%. Their stroke rate is tiny, 5 out of 1,000, really small, so really safe, excellent surgery. But the learning curve, which is pretty interesting, they started at 195 minutes for their case. And what do they do, by the way? It's a robotic lemur takedown, then it's a 4-centimeter thoracotomy, then it's an off-pump sort of mid-cab technique. So really nice technique there, nice and neat. So the interesting thing was 195 minutes at the start of the learning curve, went all the way down to 176 minutes. They tour off 20 minutes of their technique, and I'd say that's not too bad, is it? 2.5 hours for a robotic lemur to LAD. That's really quite good. But how long did it take to get that learning curve down? The other really important thing is their conversion rate started at 4.4% and went down to just over 1% at the end. But where did the learning curve flatten off? Well, the answer was that perhaps the learning curve is around 250 to 500 cases. Wow, that is a big learning curve. Now that's pretty surprising, really, isn't it? That is quite hard. And I think in the future, we're going to be able to get these learning curves down. We'll talk more about the amazing Versys system later, but they've got virtual reality headsets for their surgeons. So they can take VR headsets, they can do all the simulation at home when they're not playing with their kids or doing something else. And actually, they can bang in hours and hours and hours of practice in the world of virtual reality. So maybe if we do that, this learning curve will go down, because it's just a technical skill, isn't it? Anyway, let me know what you think. How can we get the learning curve of robotic cardiac surgery down from 500 cases to something a little bit more manageable? So that was our journal and news scan, and now I'll hand over to Camlin, who will tell you what else we have on CTSNet.
Will you be at the 103rd AATS annual meeting this weekend? Come visit CTSNet at booth 130 to meet the staff and ask questions, get an exclusive preview of our new website, and pick up some fun giveaways. CTSNet is the largest network of cardiothoracic surgeons in the world, and we would love to meet you all in person.
So welcome back. So we've picked 3 really good bits of content for you. So we do some webinars on CTSNet. If you're holding a web conference or a webinar, please do get us involved, and we'll host it live to anyone in the world, so it's there for posterity and forever. And the ERAS Cardiac Society got in contact with us, and we did a webinar together. The title of this was Improving Outcomes in Patients Requiring Mechanical Circulatory Support. These are becoming more and more common these days, and they're really high-risk patients. And this was a wonderful 1-hour webinar, completely free online for you to watch. There were 2 really good presentations. The first by Edward Soltes from the Cleveland Clinic, and the second by Michael Kindu. And Roberto Larusso was online, Lauren Barron, Daniel Engelman, Rohan Salanga, and Subhase Chatterjee. So a real stellar group. There were some really good interactive questions afterwards. And the 2 talks, the first one was by Edward Soltes, was all about can preemptive temporary mechanical support enhance recovery following high-risk cardiac surgery, asking the question about whether you should put impellers or even put them on a temporary VAD, and who should you choose. Really, really interesting. And the second one was outstanding. Michael Kindo was talking about ERAS for durable VADs. If you're putting a permanent VAD in, or a VAD to transplant, or whatever, how do you do the best for that patient? And he showed some wonderful information. So he was talking about pre-op optimization, exercise, diabetes, nutrition, opiate-free analgesia. He showed some videos of his patients on bicycle pedals while still in their bed, linked up to thousands of instruments. Really, really great talk and a really good discussion. So well done. They also just mentioned that we'll have further in the series, and we're really grateful to the ERAS Cardiac Society for giving us that wonderful demonstration. The second video we've selected for you is a little bit similar. It's on post-surgical pain after cardiac surgery. This is an allied health presentation by Kari Han Yelo from the Norwegian University of Science and Technology, and it was part of the Connecting Patients, Clinicians and Outstanding Care series that Jill Lay and Tara Bartley put together. It was really good. It was all about multimodal analgesia, opiate-sparing analgesia, CBT, and getting the patient to understand the pain they're going to have after surgery. They even touched on music, massage and acupuncture after surgery. We actually have an acupuncturist on our service that gives acupuncture after cardiac surgery. It works. So really, really good video. So check that out on CTSNet today. And then the third video we've got for you is a real eye-opener. Imagine, have you ever had that call? We're worried that this patient's had a ventricular left free wall rupture. I've only seen a very small number in my practice. I've seen a lot of them not make it, but this was a really successful video by Jad Malas, Dominic Megner, Joe Chikwi from Cedars-Sinai Medical Center. And they document a really young patient, 53 years old. They had a left ventricular free wall rupture that was contained. They came in, they had a CT scan, they had an angiogram, blocked circumflex, and they brought them to theatre. So, and they got a really good head cam footage. They opened the chest, loads of clot everywhere, a 6-centimetre hole in the left ventricle that they demonstrate beautifully. And then they do this great patch. They take 2 bovine pericardium and they put a Teflon patch in the middle and sandwich it all together. They take massive 2O-ethibond plegited sutures going through the good bits of the left ventricle, and then they patch that down. They do a load of 4O continuous, they put a load of bioglue on it, and they have a great outcome. That patient left hospital 9 days later, and 4 months later is doing really well with no chest pain. So congrats to them. Amazing video. You should really check that out now. So we're getting to the end of our podcast. Thank you for staying it out this long, listening to me honking on. But we've got a few more really exciting things for you. We've got upcoming events. We've got an honourable mention. And in that, I'm going to tell you all exciting stuff about robots. But first of all, remember the AATS is only a week away. It's May the 6th to the 9th. So I hope you're going already. Otherwise, we'll bring you the best news from that next week. The second interesting thing, just look out for May the 10th to the 13th. It's the annual London Core Review Cardiothoracic Surgery course. If you're a trainee or resident or want to top up your knowledge, this is a stellar group of presenters. Jabreen El-Khoury, Tyrone David, David Taggart, Karen Redman. You know, it's just a professor fest. So you can actually join online. There's an online subscription. And we're really excited to tell you that we're going to get the recordings of some of these. So on the upcoming 2024 course, we're going to release a load of these videos as well. But if you want to see it less than 6 months away, then just log on and have a look at that. And thirdly, the 23rd Brazilian Thoracic Surgery Congress is happening on the 17th to the 19th of May. I actually went and visited Porto Alegre and did some surgery with the wonderful surgeons there. There really are fantastic surgeons in Brazil. You know, some of the best surgeons, some beautiful centres there. So really interesting, really exciting. So check that out. They've got lung transplant, they've got ECMO, tracheal surgery, and it's a huge country. So check that out. We always have a weekly session of Where's Diego? Diego, the world's best thoracic surgeon, traveling the world to spread the word. This week, he started off in Bielefeld in Germany, where he did 2 robotic segmentectomies, and then he flew over to Kuwait, where he did 4 uniportal VATS cases, including one in an 11-month-old baby who had a huge bronchogenic cyst. So well done, Diego. There's a few videos online, and that was really, really interesting. And then we come to our honourable mention, and our honourable mention this week is to Mark Slack. Well, some of you might not know who Mark Slack is. He is originally a gynecology surgeon in Cambridge, but in 2014 he had an idea. The idea was, let's break the monopoly of robotics, and so he set up Cambridge Medical Robotics with some engineers and some philanthropists. So from 2014, where he had an idea in a pub, to 2023, this is now a £3.9 billion company. He has an active working robot. It's now done 10,000 cases worldwide. There's 130 systems around the world, and he's just amazing. He's the most wonderful, amazing, enthusiastic person. And I was in Papworth this week setting up the thoracic surgery program there, and I can tell you it works brilliantly in the chest. So the exciting thing is that probably within the next 6 months they're going to get American FDA approval, and he's also talking about coming to cardiac surgery. He really understands the frustrations cardiac surgeons have with lack of access to robotics. So CMR are certainly looking into probably starting with Lima and Rima takedown, and then who knows how far it'll go, really. So well done to them. Some of the really other interesting things we discovered talking about robotics is the really how difficult it is. So Johnson & Johnson, you may recall, had a Verb Surgical link up in 2000. That fell to pieces and they closed down that program. They then announced the Tava program, and they spent, probably it's rumored to be about $1 billion trying to set up a robot with that. That has just shut down as well. They've thrown up the white flag for that. So, and Johnson & Johnson realize the importance of robotics. It is a fact that if a robot goes into a hospital, the revenue from non-robotic kit goes down 20%, because suddenly you're not using the non-robotic stuff. You're not using the ligashore. You're not using the harmonic ace. You're not using their ports. So it's so vital to have a robotic platform. So it's heavily rumored that Johnson & Johnson may be buying CMR. Watch this space. And I think that could only be good for competition, especially when it comes to America. So let's have a look. Let's see what happens. And also keep a really good lookout in the world of thoracics and cardiac surgery, because there could be some great more videos coming out of these platforms in thoracic and soon cardiac surgery. So honourable mention, Mark Slack, great job. You're one of my amazing heroes. And see if you can find some videos or even TED Talks from Mark Slack online. He is an inspirational person. So that's all we've got time for. Thank you for sitting out to the end, and tune in next week where we'll give you some more news and information from around the world here at the CTSNet podcast.